Next up is Tony Realini, professor, West Virginia University. And it's good to see a lean and mean Tony Realini.
Thanks. Good. Is it still morning? Good morning, everybody. Thank you so much for the invitation to be here today. Today, we're going to talk about starting therapy, medications versus SLT versus sustained drug delivery. I don't think I'm going to say anything that could be construed as promotional in any way. So we'll see how that goes. I'm going to skip over these couple of slides here because we've already covered that already. Once we've decided that we're going to treat someone, we have three options, really. We have medications, we have laser, and we have surgery. And medications have been our approach for a very long time. Anybody recognize this plant? This is the Calabar plant, Calabar bean, which was our very first glaucoma medication dating back over 150 years ago. And ever since then, we've been pretty much married to the medication first approach to glaucoma and damn all the other options. And for years, it's been medications followed if needed by laser, followed if needed by surgery. This is a paradigm that generally prioritizes safety over efficacy. I mean, surgery ultimately, if you want to get the pressure down, you do a trabeculectomy. But if you want to adopt the most high risk of all the treatments that we could do, you do trabeculectomy. So, you know, it's a balance. This emerged in the era of ALT and the Cairns trabeculectomy, maybe not the non-medical procedures that we're relying on earlier in the treatment cascade now. And the relative efficacy and safety of these various treatment modalities continue to evolve as new therapies emerge. There we go. Don't get me wrong, medications are very effective and very safe. Every medication that we use in the United States undergoes rigorous multi-clinical phase testing, including phase 3 testing, which assesses both efficacy and safety. And without meeting benchmarks for both, the drug doesn't make it to market. If you don't believe me, look around and try to find your prostaglandin beta blocker fixed combination product here in the United States. They're available everywhere else in the world, but not here. In addition to their ability to lower pressure, which is established in phase 3 studies, they've also been shown in multiple landmark clinical trials to reduce progression rates. So they not only treat IOP, they actually alter favorably the natural history of the disease. But they have a few limitations. Adherence is a big problem. So is adherence. Adherence is an issue. Getting people to take their meds is really tough, and there's a really high non-adherence rate. Plus, adherence is an issue. Side effects and tolerability are issues as well that, believe it or not, lead to issues with adherence. Cost can be a problem, which makes people not take their medicines, which I guess you could call an adherence issue. And then there's this wonderful spiraling cycle where you prescribe medications and patients take them and don't like them and don't take them, and their pressures go up. So you give them more medicines that make their eyes even more miserable, so they don't take them. So you give them more medicines, which make them even more miserable, so they don't take them. And it becomes a really interesting vicious cycle that we heard an awful lot about in the last talk. Non-adherence in various published studies ranges between 30 and 80% of our patients, or 30 to 80% of the doses that our patients are supposed to take. It worsens over time. So the longer you have glaucoma, the less likely your patients are to love their medicines. There's a real incentive issue. There's no perceptible benefit. I've said before that the only symptoms that a well-controlled glaucoma patient will ever experience are the side effects of treatment. A lot of reasons not to take medication, very few to take it from the perspective of the patient subjectively monitoring their glaucoma symptoms versus their treatment symptoms. There's both intentional non-adherence and unintentional non-adherence. Some people like to avoid the side effects, or they believe that therapy isn't needed or isn't effective. But then there are those who just really can't take their drops. And these are really common problems. I mean, the overall failure rate, it's not easy to put an eye drop in your eye. I don't know how many of you actually use eye drops on a regular basis, but when I touch my cat and then touch my eye, which I try not to do, try not to touch my cat because I really don't like cats. I have a 20-year-old cat who will not die. And believe me, I've tried. But anyway, when I have to put my allergy drops in, it's always interesting. I end up having to, I don't know, they end up somewhere on my forehead, and then I just kind of do this a whole lot of times until it finally finds its way into my eye. And if I can't figure it out, I can't imagine that Mrs. Schlabodnik in my practice is getting them in on a regular basis. Contamination, missing the eye entirely. I'm sure we've all seen Alan Robbins' video in which he photographed a woman, I'm not sure from where. She sounded like she was from somewhere within a 10-mile radius of here in the video. And she was going to demonstrate to everybody how to put a drop in. And so she put her head back, she put the drop in, she sat back up, blinked a few times and said, "Where the hell did it go?" And it's a great video. If you haven't seen it, you got to see it. It's hard to squeeze some of the bottles, and some of the bottles you shouldn't squeeze, like some of the PGAs, because you'll get a week's worth all at once. All sorts of things that can go wrong and make it really, really hard to use drops, even if you want to. Consequences of non-adherence, the fewer drops you take, the more likely you are to progress. It's just that simple. You know, if you don't treat your glaucoma, it's going to get worse. So what are some of the options? Let's start with sustained release drug therapy, because we actually have a few options now. We have the bimatoprost SR, the Rista, this tiny little implant that you can stick through the cornea. 2 major phase 3 clinical trials have evaluated this. These were identical 20-month studies with 3 treatment groups. Bimatoprost SR, either the 10 milligram or the microgram or the 15 microgram implants that were done 3 times once a month for 3 months, versus topical timolol in the third group. Interestingly enough, well, let's see. The outcome here was seeing whether or not the implant was non-inferior to timolol at week 12 in terms of IOP reduction. Can be implanted in the OR or the minor room with an operating scope. 1 study eye per patient. This is kind of interesting. The fellow eye in all 3 groups got timolol. Now, that's a really cool study design, because we all know that timolol is going to lower pressure about 1.5 points in the fellow eye. So that's a really interesting study design. And I'm not going to go through all the details here, but suffice it to say that both Artemis 1 and Artemis 2, the primary endpoint was met, and the sustained release bimatoprost implant was non-inferior to timolol. However, there was a little bit of an issue in that with repeat dosing, the cornea took a serious hit. And the proportion of eyes with a 20% or greater reduction in endothelial cell density continued to rise over the period of time when people were getting retreated. This was true in Artemis 1 and in Artemis 2. This led to the problematic label although it was approved in 2020, it was for single use only, which is in that it was designed to last 4 to 6 months. That makes it more of a stopgap approach than a long-term solution to glaucoma management. There has been a single phase 1/2 study done looking at single administration, and this was at the 10 microgram dose, and the median time to retreatment or treatment escalation was about 9 months. 24% of patients required no additional therapy through 24 months, so it can last longer in some people. Why is a puzzle, because these things get drug depleted within about 6 months. So it's really interesting to try to understand what changes these may be causing in the eye and in the ocular physiology and aqueous regulation that the effect endures for a year or more after the last molecule of drug has left the system. There's now the travoprost implant. This is a little thing that goes into the trabecular meshwork, kind of like an eye stent. Also, multiple phase 2, phase 3 trials. Only 1 to date, I believe, has been published. 3 treatment groups. There was a slow eluting implant, a fast eluting implant, and also timolol. The outcome here was, again, 12-week non-inferiority to timolol. This is placed surgically in the operating room. 1 eye was enrolled, and the fellow eye continued its existing therapy, whatever it was. Whatever they were on at study entry, they continued in the fellow eye. If they were on a beta blocker, they got the benefit of a contralateral effect. PGAs, generally not much of a contralateral effect. And the non-inferiority criteria here were met also through up to 12 months of follow-up. And this drug was, let's see, the side effects here. Iritis, increased IOP, and blurred vision were the most common. They were tended to be mild and transient. There were 4 serious AEs of increased IOP, 1 retinal detachment, 1 endophthalmitis. These are not benign treatments. No eyes getting the slow-eluting implant had corneal endothelial cell density decrease of 20% or more. So this seems to be a little bit kinder and gentler on the cornea. It was approved in just the end of 2023. No restrictions on repeat therapy. However, we made the implant may last for up to 3 years. In the phase 3 study, 81% of the eyes were still medication-free at month 12. So the longer duration of activity has a chance, I think, of making more of an impact in our current treatment paradigm. Oh boy, let's talk about SLT. Now my eyes light up a little bit. We got to start with the light study because that's really the paradigm changing study. This was a study done in the UK with 718 subjects with mild to moderate POAG or high risk ocular hypertension. These were newly diagnosed treatment naive patients randomized to SLT or medications. A target IOP was established and treatment was advanced when IOP exceeded target by a certain amount on a certain number of consecutive visits. And the outcomes measured at 3 years in the initial study were primarily quality of life and secondarily glaucoma outcomes. Now, none of us would have picked quality of life as the primary outcome in a glaucoma study, but as Gus Gazzard explained to me, that was the will of the funding agency. And if you wanted to get the study done, that was going to be the primary endpoint. And so that was the primary endpoint. Not surprising, well, maybe surprisingly, quality of life at 3 years was not different in those who had to take drops every day and those who didn't. The problem with that is that it would suggest that people tolerate their drops and they don't bother them. But that's not necessarily true. The instruments that we have to measure quality of life in glaucoma are all related to glaucoma's impact on quality of life, not treatment's impact on quality of life. And all of the patients in light had glaucoma or ocular hypertension. And so it's not surprising that an instrument that measures the impact of disease on quality of life showed no differences between two groups that had the same level of disease. We need good instruments to measure the impact of treatment on glaucoma if we want to understand the impact of treatment on quality of life. So at 3 years, the clinical outcomes were quite favorable. 80% of the eyes were at target without medications or surgery after SLT. And 80% of those only needed a single SLT to reach that 3-year mark without any need for medications or surgery. Glaucoma progression was more common in the medication group, despite the fact that pressures were roughly equal in both groups, probably because patients took their drops certainly before they were coming in for study visits, but maybe not so much in between. And that's the adherence effect. Cataract surgery was more common in the medication group. It's not entirely clear why. Most large studies have shown that medications don't seem to increase the risk of cataract formation. Maybe laser is protective, but who knows? Glaucoma surgery was more common in the medication group as well. And again, this is an adherence benefit or detriment, depending on your perspective. SLT was also more cost-effective than medications in the long run. I made that statement at a talk a few years ago, and someone stood up and said, well, in my country, no one has to pay for their treatments, so cost-effectiveness is irrelevant. And I said, well, your government pays for it, right? I mean, the patient may not, but somebody does. I mean, these drops don't fall out of the sky. The lasers don't manifest themselves overnight from the laser fairy. Somebody pays, and whoever pays will benefit from starting with laser first. Safety-wise, there were no sight-threatening complications of SLT in any eyes in the light study, and only one post-op IOP spike that required medications. This is vastly different from our experience in most other studies where laser was used as an adjunct, and would suggest that perhaps chronic medical therapy or later stage glaucoma has some effect on the meshwork that makes it less tolerant to the short-term effects of laser. The 6-year results of the light study just confirmed everything that we learned at the 3-year mark. 70% of the SLT eyes remained medication-free and at target at 6 years. There was less glaucoma progression with SLT versus medications. That was statistically significantly so. Lower trabeculectomy and cataract surgery rates with SLT. And again, through 6 years, no serious laser-related adverse events. This should change the way we do things. And it has in the UK. The National Institute for Health and Care Excellence has recommended, and the UK's National Health Service has adopted an SLT first approach for glaucoma patients who are newly diagnosed. We don't have a national health service in the US that basically tells physicians that this is how you should do it if you want to get paid. So adoption here has been a little bit slower, but at least the American Academy of Ophthalmology's preferred practice pattern now recommends SLT as initial or adjunctive therapy. So that's a guideline evolution that's been 10 plus years in the making. There's a lot of innovation going on in SLT right now. The direct SLT, many of you have heard of this. This is laser delivered directly to the perilimbal region without the need for a contact lens or coupling agent. So it's a much more pleasant experience for the patient. It's completely automated. My cat could do it. I mean, she's old, but she's not dumb. And when I say my cat could do it, I actually mean that, because the whole machine, the process, there's a start button. And her paw, she's heavy enough that her paw could press that if she wandered over that way. I mean, she's always getting on my laptop and pushing buttons and making things happen. So she could do this. And once you push the start button, the voice says, place your chin in the chin thingy and your forehead against the forehead thingy and hold still. And then once it auto aligns and auto focuses and it determines where the limbus is, and then in 1.7 seconds, it delivers 120 treatment shots. If you look away, it stops. And then when you look back again, you can restart and finish. It picks up where it left off. Completely automated. Equivalent to standard SLT in a single pivotal trial, the Glorious study. I was the medical monitor for that study. Cleared by the FDA in December. That's going to, I think, significantly change both the frequency with which SLT is delivered, as well as likely the settings in which it is delivered. I should also say a few words about the COAST trial, clarifying the optimal application of SLT therapy. This is a multi-center prospective randomized trial supported by NIH that I serve as the study chair for. And it's designed to look in patients who are newly diagnosed with mild, moderate POAG or high-risk ocular hypertension. What's the best energy level for initial SLT? Can we get the same effects if we turn the laser energy down? And what's the best energy and interval for repeat SLT? Should we stick to our current paradigm, which is PRN retreatment when the effect wears off, when the tissue becomes impaired again, and then we go in and try to rescue it with repeat therapy? Or would a low energy annual treatment, regardless of IOP, keep the meshwork healthy and happy and help us to keep IOP regulated for a longer period of time? If we can maintain tissue health rather than trying to rescue it, we may keep people SLT responsive longer. So as we're trying to, if we decide that there's value in a drop-free lifetime for our patients, then how might these new treatment options evolve our treatment paradigm? I think it's entirely reasonable and completely evidence-based to start with SLT. How we deliver SLT may evolve over the next few years, but certainly SLT as the modality makes a lot of sense. It's more effective than medications because there is no non-adherence if you show up for your laser. It's safer than medications. It's more cost-effective than medications, and it has a broad applicability. We've done a number of studies in the Caribbean and Afro-Caribbeans and shown that the responses that Black patients have are at least as good as those that white patients have. And a number of other studies looking at the effective race have found no significant difference in outcomes between white and Black patients. Some of the medications and some of our surgeries do actually have differential effects based on race and ethnicity. SLT does not appear to. I think in people who have maximized their SLT responsiveness, we can move on to sustained release drug delivery. Here's an interesting question, though. I want to stop. How long does SLT last? When your patients ask you how long is it going to last, what do you tell them? We're talking about primary SLT now in a newly diagnosed patient. How many of you tell them 2 to 3 years? How many of you tell them 5 years? How many of you tell them 6 to 7 years? Right. So there are only 3 studies that I'm aware of that have assessed long-term duration of effect of primary SLT. One was the LIGHT study. At 6 years, 54% of patients were still well controlled after their first SLT. So the median time to retreatment is more than 6 years in the LIGHT study. There's a retrospective 10-year primary SLT study, single center, that reported that the median time to retreatment was 6.75 years. In our West Indies glaucoma laser study, we found the median time to retreatment after first SLT was 7.2 years. So there are 3 studies now, all of which seem to be converging in the 6 to 7 year range. And I would not have guessed that until just the last few years as these data are emerging. But we're missing the boat if we're doing SLT as adjunctive therapy. We really should start with it as first-line therapy. Once we've exhausted that, sustained release drug delivery has a lot of benefits to it. It's less effective than topical medications, at least less effective than topical PGAs, probably because of receptor supersaturation and downregulation over time. But the improved adherence may offset this. It's very costly at present. It may become less costly down the road. Delivery is associated with potential sight-threatening complications. You can have blinding complications of this treatment. I think after that, hopefully, we'll have MIGS procedures that have meaningful IOP and sustained IOP and medication reductions that maybe will converge around 1 or 2 of them, as opposed to arguing over which of the 97 of them is the right treatment for this patient or that patient. It's the logical next step in a drug-free approach. There's a higher risk than the sustained release drug delivery platforms, but likely less risk than topicals or filtration surgery over the long run. Little is known about primary MIGS before topicals, so we don't really know how effective it will be in this setting. Probably not any worse than in the current the studies that we're looking at now in patients who are either medication uncontrolled or intolerant. And some analyses suggest that MIGS before topicals may be cost effective in the long term. I think if you've made your way through SLT and sustained release drug delivery and MIGS, now is the time for us to start the topicals and start, as one of my patients said it, start putting those poisons in the eye. Given the limitations, it's reasonable to save these as a last resort before filtering surgery. The law of diminishing returns, though, may favor skipping them entirely. Let's face it, anything that you save 4th line is not likely to pull out a Hail Mary because you've already failed 3 lines of defense. And the eyes that make it through 3 different therapies and are still not controlled are the eyes that are recalcitrant to treatment and may require surgery to begin with. And then ultimately, we're at filtering surgery. If you look at this cascade of events, the likelihood of reaching the need for filtration surgery with this approach is pretty small, and we may be able to avoid surgery in the vast majority of our patients with an approach like this as our options continue to improve in terms of sustained release drug delivery and MIGS. It's the treatment of last resort when all else fails. It's a double-edged sword. It's the most effective but least safe, and it's reasonable to save the highest risk intervention for those who fail everything else first. Thank you.